However, collecting evidences and planning the program was one of the key features of the BAGALKOT demonstration project. In a concern such as HIV, our capacity to do evidence-based planning depends on our ability to involve the community. Dr. B.M. Ramesh from Karnataka Health Promotion Trust will explain.
So one of the key features of BAGALKOT demonstration project has been evidence-based programming. BAGALKOT has collected a lot of evidence at different stages of program planning and implementation, and one of that definitely was the pre-program assessments. That is, before we started the program, we gathered a lot of information which are useful for program planning, effective planning of the program. So when we do this kind of pre-program assessments, what kind of information we require? Definitely one of the information would be to collect data on distribution of population, where and how many key populations are there in a particular district. So to get a fix on the locations and denominators, that's one of the major objectives of any pre-program assessment, so that we know which are the villages or talukas where we need to prioritize our program, where we need to implement, where we need to plan our program. Along with this, we also need to know a little more about the population which we are going to cover in our program. For example, if you take the sex workers, what is the structure of the sex work in a particular place? How is it presenting itself? What is the different typologies of sex work that exist in a particular district? What have been their practices, knowledge of healthcare providers, and also, for example, some of the behavioral indicators that we may have from this female sex workers, so that we use this as a kind of a baseline, as well as we use this information for planning in terms of what kind of behaviors need to be changed or targeted in our project. The other aspect of pre-program assessment is also kind of how do we involve the community in the gathering of this information, and how that helps to develop trust, rapport with the community, so that we have from the beginning of the project itself, we have the community buying into this whole process of evidence programming and monitoring.
Let us briefly see how the learning of this kind has been articulated and implemented in different studies.
This is about the community prevalence study that we did at the beginning of the BAGALKOT demonstration project. Probably this is a survey first of its kind in the whole of the country, where a project, in order to understand the baselines, prevalence and the behaviors, conducted a comprehensive survey using a random sample, representative random sample from the community. So this is a community based HIV prevalence study. This helped us to understand the prevailing levels of HIV in different population groups like rural or urban, male, female, and also by age, marital status, education, occupation, and also to some extent caste and tribal groups. Now, this survey basically collected data from a representative sample of 4,700 persons, both in rural and urban areas. We have men and women also in this group. We had selected 10 villages out of all the villages in the talukas that we have done the survey, based on the probability proportion to population size, and 20 urban blocks were selected from the NSSO urban block frame using the systematic random sample. So as you see in this graph, The overall prevalence in the district estimated by the survey was 2.9%, which compares very closely with the ANC Sentinel surveillance data for Bagalkot district in the same year, which was 3.1%. We also see from this kind of this graph that the prevalence is higher among males than females, and also prevalence is higher among in the rural areas than in the urban areas. So this helped us to understand at that point in time, the beginning of the project, the current levels, and also a lot of information on behaviors were collected. Although some of the risk behaviors reported in the survey was influenced by the social desirability biases.
Prior to the implementation of the project, it was necessary to do a situational needs assessment, go from village to village and do social mapping, polling booth survey, household survey, and healthcare provider study to understand the needs of the community.
In this Bagalkot demonstration project, one of the evidences that were collected during the situation assessment was on sexual behavior. As we all know that sexual behavior questions are very sensitive and they are subject to certain social desirability biases. So we kind of developed, tried an alternative method which we hope has reduced social desirability biases, and that is the polling booth survey.
A polling booth survey is conducted with a group of 10 to 12 respondents. Participants are separated from each other in a polling booth environment. Each participant is given 3 boxes, red, green and white, and a pack of cards. The cards are numbered corresponding to the number of questions asked. The cards are stacked in serial order. The responses. The card with the number corresponding to the question asked is put into the green box if the response to the question is yes. The card is put into the red box if the response is no. The card is put into the white box if the question is not applicable. The moderator explains the polling booth survey method with an example and a practice session. Questions are read one by one. In the end, the number of cards in each box for each question is tallied and recorded in a reporting format. A representative sample of the following 6 demographic groups participate: unmarried males age 15 to 24 years, unmarried females age 15 to 24 years, married males age 15 to 29 years, married males age 30 to 49 years, married females age 15 to 29 years, married females age 30 to 49 years.
This polling booth survey was done as a part of the rural SNA at the beginning of the project, which covered about 1,000 individuals in half of the gram panchayats in the talukas that we covered. In this polling booth survey, we really saw that a substantially large proportion of people have reported extra or premarital sex with the unmarried or married men. About 17% of married men in the polling booth survey have reported that they have visited a female sex worker. So this shows that a large proportion of the people are engaging in some of these high risk behaviors for HIV transmission. And 18% of the married women have also reported having either premarital or extramarital sex. 12% of the unmarried women also have reported some kind of previous abortion. which shows very clearly that in this population, in this particular district, in general population, men and women, married, unmarried, they are engaging in the high risk sexual behaviors. And it also showed that it's important to address in the program we need to address these kind of behaviors, and if we had not collected this kind of data, we would not know basically what kind of behaviors should be focused in our outreach activity and in the program. We think that these are the behaviors, so we know that this is the kind of level or prevalence of such behaviors, and how can we make changes in these behaviors. So this kind of evidence really helped us to plan our outreach activities. As you see in this graph, a large proportion of men and women have reported sexually transmitted infections, STIs or STDs, that's what we call, and in the last 3 months, which shows very clearly that there is a burden of STIs in the population, and we need to provide services for the treatment for these infections. So it is not just important for the project to emphasize on the information which is required for behavior change in sexual behaviors, but also to provide services which are easily accessible, high quality services for the treatment of STIs which are experienced by the men and women in the community. So this information from the polling booth survey, a high reporting of STIs, helped us to better design our project in terms of including provision of high quality services, acceptable services to the community. So another piece of information, very important information that came from the polling booth survey is the condom availability and accessibility. As you see in this particular graph, a large majority of men and women reported that they have never seen a condom. And for most part, condoms were not easy to get. So we had also asked a question on how easily you can get a condom. So this shows very clearly that condoms, though men have slightly a greater proportion of men have reported that they have seen condom and they can easily get condom, a large proportion of women have never seen a condom, or they feel that it is very difficult to get a condom. If you some of the qualitative data that came from this situation-based assessment also indicated that the unmarried women, they often feel very embarrassed to ask the A&M for condoms. And also there are a lot of misconceptions around condom, the men saying that we should be using condoms only with sex workers, and if your sexual partner is looking healthy, you don't have to use condom. Such kind of misconceptions, myths around condom use was very much prevalent in the district, and all this came in our situation assessments. So what is the implication for program design from this kind of information? One, we need to make the condoms more easily available, accessible, acceptable to the community. So the stigma, misconceptions around condom use, as well as difficulty in getting the condoms, should be kind of addressed in our program. From the study of female sex workers, one of the important elements that we kind of came across was the client volume. Because this HIV risk is directly linked to the number of clients that the female sex workers entertain. In Bagalkot, we wanted this information to be collected and also use this information for better planning focus for the program. For example, in Bagalkot, in a month, there would be about 15,000 interactions between the female sex workers and the client. Now, out of this 15,000 interactions, how many of them are contributed by high volume sex workers? Now, can we say, for example, that out of this 15,000 interactions, what proportion of our sex workers who are high volume, they contribute to this? The study clearly showed that about 66% of the total sex work volume in the district is contributed by high volume sex workers. Here high volume we mean by those who entertain 10 or more clients a week. So which means that by just focusing our attention efforts to this high volume female sex workers, we will be able to cover a large majority, 66%, 2/3 of all the transactional sex in a particular district. So we also know that this volume itself is related to the age. For example, the younger the sex worker, she is more likely to entertain more clients, a high volume sex worker, and also the brothel based ones. So the typology where the sex work happens, is it at home or a brothel or a street, that also determines this kind of a high volume status. So this kind of information on client volume gave us direction as to how to do this kind of a program. Where do we focus? What kind of focusing, or what target groups, what focus would help us to achieve what kind of outcomes for the project. So this information was very important for the program design. Another piece of evidence that helped us in designing the project was the study of healthcare providers. We did a complete census of all the healthcare providers in Hubli-Dharwad Municipal Corporation area, as well as some of the urban and rural areas of Bagalkot. Now, the study covered a lot of areas such as the practices of record keeping by the healthcare providers and the kind of training they ever had on HIV and STI care, especially syndromic case management approach, as well as their understanding of HIV and AIDS and STDs, and when do they refer people for testing, what are the kind of dilemmas that they have in disclosure and things like that. So there is basically a report on the healthcare provider study which we can refer. I just wanted to highlight one point from the study which helped us to design the overall training of the healthcare providers under ICHAP. If you look at this table, basically the percentage of the healthcare providers who see a particular number of STD patients in a month. Now, say for example, of all the 998 healthcare providers that we studied, 50% of them don't see any STD patients. So straight away, we don't have to train any of those people in syndromic case management or on HIV. Our priority should be somewhere here, which is about 14 plus 4% who see 5 to 25 plus STD patients in a month. And since we have done this is a complete enumeration census. Now this helped us to identify the doctors who see STD patients, high volume doctors, and we can train them in syndromic case management and HIV. And in fact, we repeated this similar exercise in all the other districts in Karnataka, and we designed the whole design of regional resource training centers. The concept of training the doctors in syndromic case approach came up from there basically.
More importantly, evidence-based planning also implies that the project has the evidence to prove and demonstrate the impact that it is seeking to make.
One of the important component of evidence-based programming is the ability to gather evidence to prove or to show or to monitor the changes that have occurred because of the program. Basically the outcomes impact of the program. And how do we kind of demonstrate the utility of all these efforts in terms of the outcomes and impact. And now Bagalkot demonstration project has collected a lot of data on various outputs, program outputs, such as how many people have been referred to VCTC, STI, treatments given, condom distribution, and how many people have been met by the link workers. So all this information, which we call as output from the project, we have a lot of data on that. I want to show you the other graph, which also shows us the kind of project outcome. If you see October 2002, what was the kind of percentage of participants who have ever seen a condom, and compared that with August and 2004 and March 2005. You see, in all the groups, for both men and women, married, unmarried, there has been an increase in the proportion who reported that they have seen a condom.
It was clear to us that in absence of intervention, the scenario would have been far more grim. Some inevitable developments were an ever-growing rural epidemic, an unacceptable level of STI prevalence among men and women, multi-partner sex, a fairly widespread norm, coupled with poor access to condom leading to greater risk of contracting HIV and recurring STI.